Samuel Institute headquarters in Alexandria, Virginia, this is On Human Flourishing. I'm Dr. Wayne Jones. We are pleased to have Helen McNeal as a guest on our show today. Mrs. McNeal is the Executive Director of the California State University Center for Palliative Care in San Marcos, California, and is here at Samuel Institute for a discussion about palliative care and its relationship to whole person healing. The word palliative derives from the Latin word palliare, which means to cloak, and as a practice, it does just that. It seeks to surround those who are ill with comfort, hope, and healing. Used to treat patients with serious illnesses, palliative care physicians focus on providing relief of symptoms, pain, and the stress of serious illness, with the goal of improving the quality of life for the patient and the family. Can you tell us a little bit about what palliative care is?
Well, Wayne, I'm delighted to be here. And, palliative care seems to everybody to be a new word, but it's interesting. My great-great-grandmother was a physician, and I have a physician dictionary that belonged to her that was printed in 1823. And it says in there palliative, and it is care that comforts, it's comfort care. It's care for those that, in that definition, it was care for those for whom nothing else can be done. That isn't today's definition of palliative care. I like to say to people, it's the best care possible for people with a serious or chronic illness. It's care that focuses on the whole person and their family. It's care that has to do with complementing curative treatment. So many people think that when they hear palliative care and you say, do you know what it is? They'll say, oh yeah, I know what palliative care is. That's hospice. Well, hospice and palliative care share the same philosophy of the importance of person-centered care for our patient and their family, delivered by an interdisciplinary team of professionals, typically provided by a doctor, a nurse, a social worker, a chaplain, and other professionals. Where it's different is that palliative care is appropriate from point of diagnosis. And I think, in fact, that's a place where palliative care can make a huge difference in the confusion of initial diagnosis faced with a barrage of treatment options and the panic. We all know that when someone gets this diagnosis of a serious or chronic illness, we stop hearing what comes after that. Well, then you are expected to sort through what you didn't hear. And I think that's a place where palliative care can really make a difference. Right. So right from point of diagnosis onwards, and research has demonstrated that when people get palliative care along with curative treatment, they live longer, and that says to me the treatment's more effective. They are happier with their care, and I usually don't emphasize this, but I think it's important, and by the way, it also saves the system money.
It sounds to me like palliative care is just plain old good care of chronic illness. I mean, is the way it should be.
It is, but it isn't, unfortunately, just plain old good care. I think what is different is that we have medicalized treatment of serious illness, and that's important. Cure is important. I'm the first one to believe in the power of both integrative and allopathic medicine. But what we have somehow forgotten about is the individual who is receiving the care, what's important to them, what gives their life meaning, what makes life worth living. And palliative care helps bring that focus back into healthcare.
I see.
I'm going to just add one thing. I often begin presentations where I introduce palliative care to folks by saying, what gives your life meaning? What brings you joy? And if we can help people have more of that, it's easier for them to heal, it's easier for them to get better, and they're finding the process much more rewarding.
Right. So it's essentially bringing the patient and what's relevant to the patient back into the center of the care process. I mean, is that what you're talking about? I mean, if you have a chronic illness, by definition, it's not curable, because otherwise it wouldn't be chronic, right?
Right.
So it seems to me that anybody with a chronic illness should have and needs palliative care.
Absolutely. Absolutely. Now, the challenge, and that's what the California State University Institute for Palliative Care is all about, the problem is a problem of workforce. Most healthcare professionals believe, as the general public really does, that palliative care is end-of-life care,
Yeah.
and that palliative care is hospice care. And so it is not, but we need to educate every healthcare professional that palliative care is appropriate from point of diagnosis onwards, and that it actually helps people heal. That palliative care can be consultative and doesn't mean a doctor gives up the treatment of his patient, but actually, Dr. Diane Meyer, the Center for Advanced Palliative Care, often says it's an extra layer of support. And wouldn't all of us want an extra layer of support when we're not well?
You bet. So part of the issue and part of the need is to disentangle it from hospice or end-of-life care, is what I'm hearing you say. Is that, how do we do that? I mean, these are clearly different. Here it's improving patient satisfaction, it's improving even outcomes, clinical outcomes, the very thing treatment is provided for, and it's lowering costs. So how do we get out, what is needed in the area of palliative care to sort of disentangle this from hospice? Has there been an effort in the palliative care movement to try to do that? And what do our listeners need to know? Should they be asking for palliative care every time they come in and have a chronic illness?
Well, the short answer to that is podcasts like this, and communication strategies is a very big part of it. We need to educate everyone as to what palliative care is. The challenge is, the ideal is from point of diagnosis onwards. If the average listener goes into their hospital with a chronic illness and asks for palliative care, unless they are an articulate advocate for themselves, it will probably be hard for them to get. And the reason it will be hard for them to get is because we don't have enough people to provide that level of care, and most hospitals and healthcare systems, I don't want to say reserve this care, but they are so backed up in referrals to palliative care that it ends up being just ahead of end-of-life care. Mm-hmm. It's the person who has the serious illness who's more likely to get it, and even the person in serious illness is more likely to get it farther along the illness trajectory. I believe over time, I think 5 years from now, 10 years from now, this will have changed. So really what palliative care is doing is helping to change the healthcare system.
Right, into a more patient-centered, cost-effective,
Yes.
System. Fascinating. Are people who provide palliative care specially trained? I mean, does your average doctor or nurse sort of know how to do this, or do they need to have appropriate training to know how to deliver proper palliative care?
So I think there's two levels to this. People who are practicing palliative care in hospital systems and palliative care experts, if you will, need specialty training. So physicians, many physicians practicing palliative care are board certified in palliative medicine. Nurses are certified. Social workers have a designation. Chaplains have a designation. So there is that. And we're championing even more education for those practicing palliative care, and more designation certifications, so that patients who are coming in know they're getting care from someone who's an expert. At the same time, there will not ever be, for the baby boom generation, at least, enough palliative care trained professionals in the expert category. There just aren't. So, because, for example, to be a physician and be board certified, you have to do a fellowship, and
that's a couple years.
And it's a year of your life doing that, and we find many people come to palliative care later on when they say, I'm no longer interested in doing, surgery and specialty. I really am interested in working with people, but they can't get board certified unless they're willing to give up a year of their life. So that's kind of hard. The real focus now, as palliative care moves out into the community and begins to cover the care continuum, is for every healthcare provider to know what palliative care is, understand basic palliative care interventions. What are the triggers for referral? When should you be looking at a patient as a referrer to expert palliative care? And also to have the communication skills to be able to have what are often referred to as difficult conversations or challenging conversations, and to listen with patients. It's not magic, but it's different than the 10-minute doctor visit when you're trying to get, a physician is trying to work it through his schedule and see 12 patients in 2 hours. Having a long advanced care planning conversation is challenging. So we think all healthcare professionals need to have that knowledge.
So there's some basic skills that every healthcare professional that takes care of folks with chronic disease needs to have, whether they get certified or don't get certified. There also needs to be a way of sort of getting that out into care networks so that it can be done on a large scale. Is that what I'm hearing?
That's absolutely correct. And that's part of what we're focusing on, is educating all of the current professionals, as well as also helping to build experts in palliative care. But no, our focus is what's often referred to as the generalist, right. The palliative care, the primary care doc, his or her staff, the social worker who's working in the hospital, a nurse who's working, someone who's working in a community clinic. We're doing a training right now on palliative care in a community clinic in California. We have a HRSA grant to do this and to work with patients who have diabetes.
I'm a primary care physician, family physician, and my daughter actually is a chaplain, a hospital chaplain right now. And I always wondered, well, who pays for this? How does this get paid for? I know I need to listen to my patients more. I know I need to not cut them off at 7 minutes and say, here's the prescription. But if I extend that and I really try to adopt some of these skills and learn about them, how do I get that covered? How does a chaplain in a hospital get adequately compensated for the kinds of support that might be needed, or the nurse or the social worker to adopt some of these care skills?
Well, there's two parts to that answer. Part one is that physician time it is possible with the right codes for physicians to be reimbursed for that time. So physician care in palliative care is paid for. Some amount of advanced practice nurse.
They need to know how to code for it, though.
They know to know how to code for it.
Okay.
Similarly, advanced practice nurse time is paid for, and some amount of licensed clinical social work time. The problem is that in many places, licensed clinical social workers are not the social workers working related to palliative care. Mm-hmm. So that's what and chaplains aren't paid for it.
Right.
Now, that's part one of the answer, the simple way in some sense. But we know that the healthcare system, the Center for Medicare's Centers for Innovation, are doing a number of interesting things to look at this issue. And what we know is that, for example, the accountable care organizations and large hospital systems that are more on the continuum of care. So they're not just a hospital, they're a hospital, they're a rehab facility, they may also have a hospice. So the accountable care organization, who's taking full continuum responsibility for care,
so comprehensive care, yeah.
are recognizing that palliative care is saving them money in many ways. First of all, it's reducing the number of emergency room visits, so it's reducing their Medicare penalties. It's also ensuring that patients are cared for in the right place where they want to be, which may often be their home. And so the savings from that, I had a physician just earlier this week tell me he had done one of our courses on the business case for palliative care. It's a 3-hour self-paced program. He did it with the health system data folks. They met over a few weeks, did the course together, were able to demonstrate that they had saved the healthcare system $2.6 million over the year.
Fascinating.
And he had no problem hiring staff after that.
Fascinating. So when he was able to demonstrate the business case, then he was able to get the staff necessary for a comprehensive system to actually adopt it.
Absolutely.
So the development of comprehensive accountable care organizations should help make this kind of care more available.
That, and I think you're going to see there are folks who are doing more palliative care in the community and taking the contractual risk, and more payer-provider partnerships. Health plans are recognizing that if they can partner up with providers on the risk, that palliative care is likely to lower the cost and actually improve the situation. So we're being innovative. It's still an innovation period, but you're seeing a lot of grant opportunities and pilot projects and things like that for covering the cost.
Let me ask you a little bit about another extender of care, which is the caregiver. Especially with an older population and an aging population. Often that caregiver is family, daughters, cousins, spouses, partners, etc. This is a huge area of both burden and perhaps an untapped resource. What does palliative care do for the caregiver?
Well, let me go back to the definition of palliative care, which is this is care for the patient and family. The patient and family are the focus of care. So palliative care recognizes that none of us is an island. We may not have a biological family. We have a family of choice, or we have our biological family, and we have our caregiver or caregivers, and that they need to be considered in this as well. So part of what palliative care does is how do you support the caregiver, and what ways can they be assisted? Because we know so often, particularly with people with a serious illness, that it is so often that something happens to the caregiver actually more quickly than to the person who's ill.
Right. Yeah, they're under huge stress, and they're also at risk for getting ill, aren't they?
Absolutely.
Higher risk than an average person.
Yes.
Yeah. So is there special training or for intervening and working with self-care for the caregiver? Is that part of what's embedded in the kind of training you're talking about, either with specialists or these palliative care training programs?
I would love to tell you, I mean, there's programs. So, for example, we provide as I said, part of our mandate is to educate the community, and we consider the caregiver as part of that community education. So we have programs called Caring for Those You Care About, caring at a distance, because so many of us do care at a distance, and that has its own unique challenges. So there are programs that we provide, and palliative care really does focus on the needs of the caregiver. The challenge is we're still very much, as a field, I think, in a transitional phase. I mentioned the workforce challenge. We say in California, for example, 80% of the hospitals have a palliative care program. That doesn't mean they all look alike.
Okay.
Some of them are a physician and a nurse. Some of them are a nurse and a chaplain. Some of them are a nurse and a social worker. Some of them are a nurse, social worker, chaplain, and some of them are what physician, nurse, social worker, chaplain, and a pharmacist.
So a mixture of
It's
things.
different things. So the amount of support that is available to the caregiver, it can be organized by palliative care. It may be provided by others. one of the important things as palliative care moves out into the community is everyone, I think, is striving to make strong palliative care community connections with other agencies, because we're not the only people that can do palliative care. What we can do is coordinate and help make it happen, but Meals on Wheels can help. Integrative therapies. My husband is a massage therapist. He loves working with people who have a serious or chronic illness. That's his focus is energy work with them, and so we can connect to other resources in the community that can help provide that support. The problem is often it's easier if those community members have resources.
Right.
And that's the sad part. We need to make it more broadly available.
One of the things you mentioned, integrative care, and I know Samuel Institute does a lot of research in the area of integrative health care. What's the role, and how does integrative care or complementary care that has not normally been part of mainstream, how does that fit in with palliative care? Things like acupuncture, Reiki, massage, and perhaps even diet and supplements and things like that.
Well, I think they play a very important part. We've defined palliative care to be patient and family-centered care. And I think that obviously anyone who is aware of, and this is the challenge of educating people about integrative care, that anyone who is knowledgeable of integrative care wants it as part of their armamentarium of things that they're using to treat whatever illness that they have. And palliative care not only respects that, but encourages it. What is it that gives your life joy and meaning? What is it that will help you heal? Not everybody else, but you.
Yeah.
And so I've always seen palliative care to be very closely integrated with integrative healthcare. As you know, I used to be at the Institute for Palliative Medicine at San Diego Hospice, and we had a very extensive integrative medicine program, and always saw that as equally important to the care that, if not more important in many cases, to the care that we were providing that might be considered medical. And that to me is how it should be. We in palliative care should be also engaging with the integrative medicine community more actively, so we know more about it. But the challenge, I think, for many palliative care professionals is that there are reputable organizations in integrative medicine like Samueli and like a number of the ones in San Diego. There are also some out there that are a little less reputable.
Right.
And providers are cautious. I think every palliative care physician will tell you the story of a patient who's come to them and said, well, if there's nothing more that can be done for me here, I'm going to Mexico.
Yeah, right, like in cancer, for example.
Right.
Cancer treatment. Right.
And maybe what they're going to get in Mexico is going to be good, and maybe it's not.
Exactly.
And so professionals are reluctant, when you're licensed and malpractice and everything else are on the line, to necessarily espouse. But when they know a provider, they have a track record, they will absolutely support it.
Right. So I think you've made a wonderful point that good integration of complementary non-mainstream medicine, integration of non-mainstream practices has to be done within the context of good, responsible, conventional care to truly be integrative. And so it can't be sort of off in a side area or a clinic that doesn't provide good general basic care. It has to be integrated with that. Even things that are harmless, if they're done expensively, or if they produce side effects, or if they're done instead of something else that works, where the evidence is not there, then they can actually cause harm. So
Absolutely.
I remember when you were vice president there at the Institute for Palliative Medicine, and I came and visited. I'd visited many integrative clinics all over the country, all over the world, and I was astounded at how seamlessly your integrative practices were built into what you did there. I thought, this is truly an integrative clinic, one of the best I'd seen actually around. So there's clearly a role there, and I think there could be, with proper integration, some enhanced component, not only for the caregiver, like we talked about before, but for the professionals in those areas, giving them increased tools that they can use that they didn't learn in medical or nursing school. I didn't learn many of these things till I got out of medical school, and then realized that there was a whole world of healing out there that, if properly evidence-based and properly integrated, could be very beneficial. I'd like to sort of go back to the end of life. I know we sort of started there. We traveled away from that and got back there. And I know you've got an appointment here at the Hospice and Palliative Care Association. But is there a problem in our society as to how we deal with the end of life? Most of the time you hear, well, the person needs palliative care because there's nothing else we're going to do for them, or they're going to die soon, or something like that. It's almost like these two worlds can't coexist. You're either in curative approach, you're in a curative mindset, or you're in a healing mindset. And I'm just wondering, is a problem with that because we just don't know how to deal with incurable illness or end of life? How do we have a good life if we can't have a good death?
Well, I'm of the school that says you can't, that knowing that we're all going to die, and being comfortable with that will allow you to lead your life more happily. But that's a personal observation. Mm-hmm. I think there's problems on many levels, and I am sure that everyone here has read Atul Gawande's new book, Being Mortal. But if your listeners haven't, I highly recommend it because he deals with this. I think for the professional, the challenges are we have created a healthcare system that is focused on cure, and when we can't fix it, we don't know what to do, so we just keep doing more of what we know how to do. And the quote that we all know and love, is if you keep doing the same thing and expect a different outcome, that's called crazy.
Right.
Well, that's what we do in medicine. When we don't know how to cure, we just keep throwing stuff at it. We'll find something else. As a patient or as a person in the healthcare system, as a family member, we play into that. We associate, we know that not being able to do anything more means we're going to lose someone we love, or we're going to lose our life. And we're in that place with all the question marks and possibly regrets, and the person may not have had a conversation. And so all kinds of things come up at that time, and it's a really stressful time. And so I think we have to educate the public about the importance of conversations. Ellen Goodman has something called the Conversation Project, which is an excellent problem. There's all kinds of activities happening around advanced care planning, and I really believe it's as simple as a conversation. And anytime you gather with your family, I encourage people to have a conversation that begins, what gives your life meaning? What brings you joy? If you had a serious illness, then what's important? What's important to you? And then eventually you will get to the place of being able to comfortably talk about dying. And then, yes, obviously we want to make sure your advanced directives are in place, and if you have a serious illness, that you have a physician's order for life-sustaining treatment, as we call it, or POLST. It's what's called in California. There are other terms nationally, but something that says, these are my wishes and I want them adhered to. But more than all that, if we've had the conversations with the people we love, with whomever we view as family, then when the time comes, it isn't as wrenching and as difficult because we know what's important to that person. And if we can, and palliative care supports that, but if we as family members can support that, because we know this is what they want, even though it may be hard for us to let go.
Yes. It's not easy, is it? Sometimes
It's
very hard. Well, at the Samuel Institute, one of our taglines is making healing as important as curing, and it sounds like you're speaking to that by appropriate listening, appropriate conversations to try to get at what's really deeply meaningful for people, and that's what actually gives them the most value in life. So I want to really thank you very much for this interview. This has been an honor. I look forward to continuing to do more and more work with you. I really hope we can do that, and I really appreciate all that you've done in this area.
Well, Wayne, thank you. It's a pleasure to be here. It's a delight to learn more about the Samueli Institute, and I look forward to the opportunity to collaborate. It would be great.
Great. The concept of palliative care as a driver for whole person healing is one that puts the focus back on the patient and their needs for healing and care at a time of serious illness. This is an integral step in changing the healthcare system to shift attention back to the care of the individual and how they define health. For some, it may mean a monthly trip to a massage therapist, adjustment in pain medications, a visit from a loved one, or simply a stroll in the park. While these are choices left to the individual, we are seeing a need for practitioners to equip themselves with resources needed for their patients and to utilize care not only during a time of illness, but also while they're well. The merger of intelligent and sensitive palliative care with curative medicine is the true integrative healthcare.